Thank you, chairpersons, for your kind words of introduction, and I thank Dr. Parveen, Dr. Saurav, and all the team of RGCRI who have organized this and have been kind enough to invite me in this wonderful conference. And although this is the last lecture, I can see you honestly that there are a lot of new things that I learned personally while I was preparing my slides for this. And it made me feel that there are a lot of things for an intensive to absorb on this subject. The subject is too vast. And talking about all the toxicities of chemo is beyond the purlance of any single day conference. But even if we cut upon the cardiac toxicities of the chemos and the reasons, then probably there are a lot of things to ponder upon. And a lot of times we can do new things and try to do better things. I will go through this and I will just to give a glimpse, I will go through some cases. And as we stroll along these cases, I will pick up the relevant things and highlight the importance of our strategies that we need to adopt. First case, 40-year-old male presented to the ER with dyspnea for a week and was intubated for acute hypoxemic respiratory failure. The patient had received 3 cycles of cisplatin and doxorubicin after undergoing resection of the osteosarcoma knee and followed by TKR. The echo was 5 to 10% with severe biventricular failure. Despite all attempts for cardiac optimization, hemodynamic status continued to decline and patient dies on day 2. The autopsy shows no evidence of osteosarcoma, but evidence of pulmonary congestion, liver congestion, and multiple body cavity effusions. So it is not that it was something metastatic, malignant metastasis, which ultimately had led to this multi-organ dysfunction. It was something different. So probable cause of death is cardiac failure. Now the question is, what caused this cardiac toxicity in this patient in this course? Now, range of cardiac treatment has increased like never before. Earlier, we had only used to have these 3 arms: the surgery, radiation, and chemo. And this has been followed by immunotherapy, hormone therapy, targeted therapy, stem cell therapy, etc. And when it is now becoming more and more clear that, as Dr. Dhar had just now spoken about precision nutrition, much before precision nutrition, precision medicine started with cancer, and personalized medicine was the key approach which was adopted, which gave rise to this. The concepts of precision medicine were conceptualized with the background of cancer in mind only. And this personalized approach, it recognizes, earlier it used to be a general procedures with including chemo, radiation, surgery, etc. But now it in the PPA model involves the subtissues and the metastasis, followed by omics analysis, followed by genetic mutations where you identify the BRCA, the HER2, EGFR, etc. And then also link them with the personal factors, because that's what also part of metabolomics, and then decide the targeted treatment. One interesting thing to know about targeted treatment is that Sidney Farber, who is considered to be the father of targeted therapy, at this, Siddharth Mukherjee writes in his book Emperor of Maladies, a biography of cancer. Siddharth Mukherjee is an Indian. He is from Delhi only, who is now in US, who has received the Pulitzer Award in 2012, I guess, for this book. And he draws inspiration from Sidney Farber. Sidney Farber was a pathologist. And Sidney Farber used to stay in the basement of that hospital in Boston. And he became interested in leukemia. And he tried to observe, and he felt that this folic acid was stimulating this leukemias in children. And he developed the aminopterin. So this aminopterin, finally he did a lot of other things. It has been long since he has passed away. But what made Siddharth Mukherjee write this book, that he was so inspired by the story of Sidney Farber, because who is concerned as a doctor of the dead, taking interest and developing a whole new branch upon which the entire target therapy is built up subsequently. And that is finally leading on to the novel therapy. So as we know that companion diagnostics is an important part of diagnostic armamentarium, because it identifies which specific investigation would lead us to the specific treatment for a patient on a patient-to-patient basis. And that is what is creating novel therapies. When we look into the cardiotoxicities, basically, many people try to classify this on the basis of 2 drugs, which are a bit of different, which are much different in the pattern of toxicities, and these are the anthracycline type of toxicity and the trastuzumab type of toxicities. But more scientific and more rational classification is to group the other classes to the anthracyclines, the epidermal growth factor, that is mainly the HER2 medications, the antimetabolites, which include 5-FU, cytarabine, etc., microtubule inhibitors, proteasome inhibitors like the paclitaxel, docetaxel, etc., platinum-based, it is known since long, cisplatin, oxaliplatin, etc., angiogenesis inhibitors. These are one of the drugs which are the game changers in chemotherapy, so to say, because a lot of the solid tumors, besides the blood tumors, have started showing good response to this, but they have also been linked to a lot of cardiac toxicities. If you want to focus first on the anthracycline type of cardiotoxicity, this can be either type 1 or type 2. Type 1 is caused by the cardiomyocyte death, either through necrosis, etc., and usually not reversible. Type 2 cardiotoxicity is a dysfunction and not a death, and therefore it is reversible. So this identification is important. There are certain risk factors like more than 65 years or less than 4, female sex, hypertension, pre-existing heart disease, mediastinal irradiation, treatment with cyclophosphamide, paclitaxel, trastuzumab, cumulative anthracycline dose, higher individual anthracycline dose, all are causes of anthracycline cardiotoxicity. And largely it is because of the generation in free radicals, which through the mitochondrial redox cycling results in LV dysfunction and leads to the severe cases of congestive heart failure. Now, how to prevent it? Use of pegylated liposomal doxorubicin has been shown to reduce the cardiotoxicity, but this is not within the domain of intensivists. It is about the choice which the oncologists have to take. But for intensivists, it is important to note that carvedilol can protect against this doxorubicin-induced LV dysfunction through its antioxidant properties, and we have used it for different reasons in the ICU. We can continue to do that in such patients too. Dextrazoxane this is an iron chelating agent, has been the gold standard to reduce the incidence of congestive heart failure and decreases in LVEF in patients who manifest this anthracycline-induced cardiotoxicity. Enalapril has also been prevented in the late decline of LVF, that is those patients who initially seem to have a normal EF, but later shows sudden and sharp decline, and they also have an elevated TROP-I level. So if that is present, then even enalapril can be used. So AC inhibitors with or without carvedilol should be considered for patients who are at risk of such toxicity. So whenever we find the risk factors which I mentioned in the previous slide, and these patients have received of late, and we see that on echo that this patient is having a decreasing ejection fraction trend-wise, then we can start using that. Let's go through this case. 60-year-old female presents with chest tightness, shortness of breath, and nausea since a day. Troponin is insignificant level, hemoglobin is normal. Patient is a follow-up case of esophagus following post-esophageal gastrostomy who received cisplatin, 5-FU, and radiation followed by Folfox and trastuzumab. The Folfox was given every 2 weeks, trastuzumab was given 3 weeks for 6 months. On ECG, the patient develops with this chest tightness, anterolateral T-wave inversions. So automatically you have to look for TROP-I, and TROP-I is negative. 2D echo shows the new anterior and anterolateral wall motion abnormalities and EF of 40%, say 30 or 40%, whatever. So in these cases, what is the cause of cardiotoxicity? Now, this has been seen in, these are some of the studies that I have quoted. There are plenty of studies on trastuzumab-induced cardiotoxicities. But one, you please note the second study, that is the Calvillo-Arguelles et al. They show that the 3-year cumulative incidence is around 35%, more common in HER2-positive breast cancer who have received more than 12 months of trastuzumab therapy. So these are the patients, because this is a large study, so in these patients, they have been able to identify the fall in LVEF by doing at least one Muga scan. The other studies also point out some figures which are significant to many. Now, any toxic effects due to trastuzumab is generally considered to be reversible following cessation of treatment, because the anthracycline-induced cardiac toxicity can persist even after stoppage of the treatment. So early stoppage is recommended. Now, trastuzumab is often given to patients as an adjuvant to anthracycline therapy. So in that case, there can be double toxicities because of its double effects on the toxicities gets amplified. So cumulative evidence of these side effects is compared to the anthracycline is greater. Now, what should be the treatment? Again, I could say that ACIs, ARBs, and the beta blockers are probably the appropriate first-line agents. They should be followed by loop diuretics, hydrolazine, nitrates, and aldosterone antagonists as per the AHA guidelines. Guidelines is there, I won't repeat it. There are newer agents which can benefit, which includes this sacubitril valsartan. And if And the calcium and ivabradine has also been shown in a good number of studies to be useful, particularly in trastuzumab-induced cardiotoxicity. For advanced heart failure, of course, this synchronization with therapy, mechanical circulatory support, etc., all options available. Now, the data are scanned pertaining to the impact of traditional heart failure treatment who patients develop already on failure. So in them, it is difficult, but those patients who are on trastuzumab and likely developing in the early stage, probably it is good enough to start and do the treatment. Third case, 40-year-old female, CS cervix, no CVS risk factors, admitted for concurrent chemo with weekly carboplatin plus paclitaxel, then followed by intracavitary radiation therapy. After completion of the first cycle of paclitaxel infusion, the patient presents with diaphoresis, decreased consciousness level, GCS has gone down to 12, heart rate has come down to 40, BP is 80/36, patient is more or less into shock. You can well read from that. The saturation is still maintained, ST elevation in the leads, 2, 3 AVL, AVF, so more than. So what is the cause of cardiac toxicity? It is not just the inferior leads, the lateral wall is also involved. Now, whenever there is platinum-based chemotherapies cause cardiotoxicity, they can manifest LV, fall in LVF, heart failure, but they can also give rise to ACS. So ACS is particularly a feature of platinum-based chemotherapies. The key aspect in platinum-based chemotherapy is the vascular toxicity, which leads to endothelial dysfunction, arterial hypertension, and that exacerbates or increases the risk of thromboembolic events as well as produces ischemia. And another important point to remember is that electrolyte imbalance, particularly hypomagnesemia, is a major concern in platinum-based chemotherapies, and that can also lead to arrhythmias and cardiac complications for which the patient may present at odd hours in the ICU. One important thing to note is that supplementation with lactobacillus can significantly counter these negative effects of cisplatin, but it can lead to an increase in the body weight also, but it will ultimately lead to a restoration of the cardiac function. So all the nutritional theories that we have heard before from Dr. Devashish also leads to point that the lactobacillus has some uses beyond that. My last case, a 76-year-old male presented with dyspnea and altered mentation for 2 days. Patient has history of diffuse large cell B lymphoma, was treated with CAR therapy, the chimeric antigen receptor. So this is the in thing, and it has caused a revolutionized our therapy in more than one ways. His FDG scan performed a week before the CAR therapy showed enhancement of numerous albuminal nodules with skeletal involvement. Baseline cardiac workup showed no structural abnormality with 2D echo, normal LVEF, 12-lead ECG shows normal sinus rhythm, baseline troponin and B12 and the BNP levels were normal. He experienced grade 2 CRS, cytokine release storm, on day 7, for which he received tocilizumab, and the cardiac magnetic resonance showed acute myocarditis based on the pericardial gadolinium enhancement. Now, this is a different type of cardiac toxicity which you have to remember in such patients who are on lymphomas and on whom the diagnostic worker who can develop for CAR therapy induced cardiotoxicity. So all the risk factors that the patients had with CRS, grade 3, old age, high lipids, aortic stenosis, high creatinine, etc. There has been several trials, the Juliet trial, the Zuma 1, Zuma 2 trials, which have shown LV dysfunction, cardiac arrest, or cardiac failure in patients with CAR cell therapy. And retrospective studies have tracked down the toxicities also to tachyarrhythmias, cardiomyopathy, as well as pericardial effusion. Now, how to monitor for CAR cell therapy? If the patient has to monitor on days 0, 3, 7 from the infusion or the beginning of the CAR cell therapy, if CRS happened on the grade 1, there is no further heart monitoring is required. If 2 or above, the patient's troponin needs to be measured daily with measuring pro-BNP. On days 0, 3, and 7, telemetry monitoring continuously and then the patient needs to be followed up monthly. And additionally, all patients with CRS grade need a cardiac follow-up with every 3 months. Now, patients with reduced baseline ejection fraction have a trend towards higher all-cause mortality, and in then the highly specific CTNT rises during the first weeks, and those are the patients who are associated with particularly high mortality. Now, there is some difference between the immune checkpoint inhibitors and the CAR cell therapy, because the CAR cell therapy elevates the immune cells against the cancer cells acting on the T cells and the NK cells. The immune checkpoint inhibitors block the cancerous protein actions on either cancer cells or the fighter T cells. So this is the basic difference between the CAR cell therapy and the immune checkpoint therapies. Both are being used. There has been incidences of cardiotoxicities with either but less with immune checkpoint inhibitors. But there appears to be some merit in the idea of using two forms of immune therapy to make the cancer cells vulnerable to the immune system. So with this therapy, probably it will become clear whether immune check inhibitors can lead to certain specific type of cardiac toxicities or not. Whatever has been reported and whatever has been published as per the US FDA guidelines, these are the MABs. We can leave the nivolumab, ipilimumab, the pembrolizumab. So they have been approved indications, and some of them have been found to produce atrial fibrillation, supraventricular tachycardia, including such like pericarditis and pericardial effusion, as well as vascular changes, temporal arteritis, cerebral vasculitis, etc. Myocarditis is the most common and most fatal. High dose corticosteroids are the mainstay of management and often guided by the severity of the adverse events. We can use imaging modalities to monitor them. Echo, MOGA, CMR, cardiac biomarkers, all of them have both advantages and limitations. But if they follow a trend, probably the easy one would be to follow the echo, followed by cardiac biomarkers, and of course, if facilities permit, to choose either MOGA or CMR and follow them up. So there are gradings of severity, and these gradings particularly refer to the immune checkpoint inhibitors and the CAR cells, although they can be to some extent differ in their grading, because this is only recommended by the Oncologist Association, not by the American Heart Association or similar heart associations elsewhere. But there are certain ways that when you can hold ICI, the immune checkpoint inhibitors, when to permanently discontinue, or when you also have to discontinue and plus start methylprednisolone in dose of 1 gram per day. So that is the grading is important. So if you think the anti-tumor drugs trastuzumab, they have a characteristic with LVF decrease over asymptomatic patients over gradual period. We can give them some protection. Anthracyclines, they can also, in addition to that, give rise to arrhythmias. Arrhythmogenicity is high congestive heart failure. The immune checkpoint inhibitors can, besides this, lead to multi-organ dysfunction. So monitoring the priorities of monitoring will vary depending upon the agent. There are certain common monitoring techniques for cardiotoxicity after all forms of therapy, and these have competing roles in evaluation because the dose and frequency varies, and the regime also varies according to the type of the cancer. But ECHO is considered as the routine test for cancer patients to continue monitoring to the cardiotoxicity. Definitely it is true, but the recent studies have showed that the ejection fraction measured by cardiac magnetic resonance has the highest repeatability compared to that which is measured by doing a 2D echo. So the myocardial deformation is measured by both methods, but there is certain, the repeatability varies. So my final take-home message would be that manifestations of cardiotoxicity due to cancer treatment includes heart failure with reduced ejection fraction, arrhythmias, thrombosis, hypertension, ischemia, etc. Mechanisms behind these effects have largely focused on oxidative stress, calcium overload, direct cardiac tissue death. Incidence of the chemotherapy-related toxicity is influenced by several factors, including the specific pharmacological therapy, duration, age, sex, and the risk factors, of course, along with the underlying conditions. The standard standard treatment for anthracycline-induced toxicity is dexrazoxane. Non-pharmacological approaches like early detection, lifestyle interventions might help, only might help to prevent or reduce such risks of cardiotoxicity. Thank you very much for your patient hearing. I think I have stick to the time.
Hello. 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 Excellent, sir. Thank you for your elaborative talk and covering all the aspects of cancer chemotherapy. Sir, I just want to ask two questions. Since how many times after giving the anthracycline group of drugs, the cancer cardiotoxicity can manifest?
How many times?
Duration of the...
Most studies have taken the standard as 3 to 6 cycles.
So no, it's... suppose if the patient has got a anthracycline group of drugs at 2014.
Okay, you mean the time, duration of onset. It has varied. It has seen as early as 15 days also in one study, but mostly it has seen that it takes 2 months to produce that sustained fall in the LVF. And LVF to manifest. LVF may fall early, but to LVF to produce symptoms, that takes around 2 months.
Yeah, sir, but we have patients seen here, the cancer chemotherapy, particularly doxorubicin group of drugs, they can present after 10 years or so.
Yeah.
with the significant fall of LVF from 55 to 15%.
That is the type 2. I had mentioned there are two types. One that is called the cardiovascular destruction, the apoptosis. Type 2 is dysfunction. So this dysfunction, if it persists, it can continue to develop after.
Type 1 is usually reversible, sir, as compared to this type 2.
Exactly.
And the second question is that how do we manage the patient which has sudden fall in LVF after giving the chemotherapy drugs and EF falls to around 20-25%? So how do we manage these patients in ICU or NCCU?
Primarily, these patients all will have fall in ejection fraction. So if in fall in ejection fraction, we need support. They need vasopressors. Basically, fluids don't help much. It's a little bit of fluids, it's fine, but you cannot load the heart with fluids. You need vasopressors and supports. And after that, the specific therapies, the AC inhibitors. All the studies have point mind-boggling effect with AC inhibitors. If you start AC inhibitors, you use along them. If you add beta blockers in case of trastuzumab, with that, a significant number of toxicities, they will start responding. So afterload reduction has got a good, a good role in reducing the severity of this disease.
Sir, we have to reduce both preload and afterload. And as you said very fairly, that afterload reduction by ACE inhibitor, ARB, and the adding of the beta blockers to reduce the contractility of the heart work best. But some now newer drugs we have in our basket, like ARNI, sacubitril valsartan.
Yes,
and,
they have also been found to be.
spironolactone.
Even ivabradine has been also tried, and it has also been found to be useful. And this usefulness have been more clearly documented in anthracycline-based toxicities, but in immune checkpoint, and probably still a lot more to come.
That was a very enlightening presentation. I have a small query about intraoperative management of patients with a low ejection fraction. Suppose there's a patient who's got an ejection fraction of 25%. Question number 1. Would you advise us to put a transesophageal echocardiography probe in that patient, or would the modern cardiac output monitors like Vigilio or Hemosphere? Or then the next question would be that suppose there is such a patient for a very minor, suppose hysto-DNC. So is it safe to give a spinal? Maybe a, say, saddle block?
I think saddle block and spinal for.
Start off with the major surgery first. I mean, TEE or.
See, whenever you talk about TE or the non-invasive cardiac output monitoring, the basic question is that will the cardiac output monitoring help? So cardiac, there is no doubt that cardiac output will definitely help. But is it going to provide useful information? We don't know, because flow track, Vigilio, they're all valid for high tidal volume ventilation, patient making no breathing. That suits the intraoperative conditions. Even if it may not suit the ICU patients, it may suit. But the kind of, with a 25% ejection fraction, your options are limited inside the OT, because you want the heart functions to improve a reasonable so that the heart bears the stress of the surgery. The surge is absent. So I think that transesophageal echocardiography is an option which may benefit without any, but definitely non-invasive cardiac output monitoring options, whether it is any of the monitors.
Semi-invasive ones, not the totally non-invasive ones, because totally non-invasive, you just clip them onto the like a finger probe.
Yeah,
semi-invasive.
Semi-invasive.
Arterial line.
One with the arterial line, whether it is PICO. But so all that, I think that has a reasonable reason to believe that they are going to help you guide the monitoring.
So you recommend them in each such case? No two ways.
If there are reasons and if they're available, I think they are good options. I can't say much about the transesophageal echo, not because I am not doing it, but because there is not enough literature on that.
I just want to add, Dr. Shagun, cardiac monitors which are invasive and which give the cardiac output as the SVR, they are much more helpful in the severe LV dysfunction patients, because we can keep the map around 65-70 and a good urine output. Transesophageal will not help so much to make the cardiac output, or is just helping ascertaining the cardiac contractility or so. So I think in a patient with a severe LV dysfunction with a EF of 25-30%, cardiac monitors are must in our better suited.
And there is no such. To ask you, there's a new parameter called the hypotension prediction index. How useful do you think it is? It claims that it can predict it with 95% accuracy 5 minutes before the episode of hypotension. It's the new one by Edwards.
HPI is recently documented. HPI is recently adding to our armamentarium, but still there's no such data to show that it can reverse to the patient can go in the hypotension or in the arrhythmia-like cycle like it. I think, but the cardiac monitors,
Utility
limited
as of
utility.
now.
But the cardiac monitors are much more helpful as compared to these things.
No, this is incorporated in that same cardiac
Same
output
cardiac.
monitor.
But I think one of the issues what we are probably debating is the issue of a static monitoring versus a dynamic monitoring.
These are dynamic.
So when you are talking about say static monitoring, I put in an esophageal probe and I'm looking at the cardiac output. That is probably to us more or less it's probably at that point of time. But if I'm talking about Vigilio or I'm talking about Pico or something, then I am talking about an intervention also, not necessarily fluids or some inotropic agents which can be given to increase. So at any given point of time, I think a parameter which is dynamic and which helps me guide my therapy, not just giving me a diagnosis that this is a low ejection fraction, which is more or better picked up with an esophageal probe. I think in those terms, dynamic monitoring would be much more helpful to us in managing those patients who are at a risk or who have developed this sort of a phenomenon.
Agreed, sir. But what I'd like to add is that with TEE also you can have dynamic monitoring.
Yeah.
If you take the IVCD index or those other collapsibility index, all those.
Well, I think for a short intraoperative period, yes, we are talking about this. But whenever we are talking about it at a lower or at a longer period, then
Postoperative,
probably that we are looking at.
I think the
something
most
else.
important thing to remember is that in these patients, they can come down, the hypotension, everything, but it is important to predict how they are going to recover. Now, in order to know that, you will have to lead the large functions of the functioning of the heart. How does the contractility, the wall movement. So all these informations can be obtained as much as from the T as from the transthoracic if you have, but these informations are required later time. Once the patient is, so in all patients at the time of surgery, restoration of the blood pressure, heart rate, all those things that you have to do, maintain them on elective ventilation and shift them to the ICU and gradually wean them all. So that can be monitored clearly with the other non-invasive cardiac output monitoring, semi-invasive cardiac
They
monitoring.
give you the DP by DT, they give you the EA dyne, they give you SVI, they give you all that PP. Thanks. And how about the patient with spinal? I mean, could you go in with a spinal? If
The
it's
spinal, see,
25%?
yeah, no, that's a sympathetic blockade. You see, if it's a cardiac, if it's a cardiotoxicity induced by chemotherapeutic agents, uh, on sympathetic blockade, we can't expect too much of extra effects. Yeah, if the heart is compromised, then the ability of the heart to respond to the sympathetic blockade may be diminished. But directly, it's difficult to predict that the spinal column. So you preload the patient and take necessary steps.
Give a low dose maybe.
Yeah,
And,
low dose,
relax.
low ad. Yeah, give some opioids, etc.
Thank you.
Thank you, Dr. Nirvan. Just one of our observations for probably a non-onco ICU people is that we feel that when we are talking about precision medicine, we are talking about a lot of medications which have come in the recent years. And the emphasis has been on efficacy. We all talk about ये बचा लेगी, ये इतना survival करती है. The issue of safety or long-term complications of these drugs, which are I think every a week you can get a new drug which is coming, and the safety or the complications which are linked to this is hardly given emphasis, and that is how the complications occur. So we have to be there that any patient who has an acute problem might be an iatrogenic or might be related to some adverse effect of any drugs rather than a new myocardial infarction which is occurring and giving rise to this. So that I think more of us have to understand that there is cardiotoxicity or any other toxicity of the drugs which might not be very well apparent to a lot of people.
As Donald Trump says that sometimes the best investment is to make no investment. So I don't know whether he comes back this time, but probably that applies to the use of monitors. Thank you.
I think we make it a call. Thank you, everybody.